This module will introduce you to the basic principles of evaluating a Bitewing radiograph. In previous modules, we evaluated a full mouth radiographic examination. We identified the periapical and Bitewing radiographs from the different locations, and we systematically evaluated the anatomy of the maxilla and the mandible. We now move on to evaluate the Bitewing radiographs. But first, let's consider why we take Bitewing radiographs, given that we have covered this anatomic region on the periapical radiographs. We take Bitewing radiographs to evaluate interproximal caries, to detect secondary caries below restorations, and to assess for loss of periodontal bone in the interdental region and in the furcation. Bitewing radiographs are quite technique sensitive, so let's quickly review the Bitewing projection. Using a receptor holder, as shown here, will greatly facilitate making an image. The sensor is placed parallel to the long axis of the teeth, and the beam is directed through the interproximal spaces and with a slightly downward angulation. To adequately view the interproximal surface, the X-ray beam should traverse through the contact point with minimal obstruction from the adjacent tooth surfaces. With an incorrect angulation, the interproximal surfaces of adjacent teeth are superimposed. Note that the superimposition will obscure details of enamel and dentin, and this will be inadequate for caries diagnosis. So how much of overlap is acceptable? Less than 1/3 of the enamel thickness. When the extent of superimposition is more, you should consider retaking the radiograph. Given the curvature of the arch, we make separate projections for premolars and molars. So what makes a good Bitewing radiograph? You need adequate contrast so that you can clearly see the enamel and dentin and the interface between enamel and dentin. You want to see each interproximal surface at least once. That interproximal surface should have superimposition less than 1/3 of the enamel. And finally, you want to be able to see the height of the alveolar bone in the interdental regions and in the area of the furcation. With that, let's start to evaluate our patient's Bitewing radiograph starting from the right side. First, let's identify areas of cervical burnout. So what is cervical burnout? It's caused by the normal shape of the tooth, and as a consequence, there's less absorption of photons in the cervical region. This makes that area look more radiolucent. So let's go back to that radiograph and make sure that we are familiar with this phenomenon. Cervical burnout will be radiolucent, it will be diffuse, and it's always located between the edge of the enamel cap and the crest of the alveolar bone. Also note how the appearances of these regions change on the adjacent radiograph, where the beam angulation is slightly different. Most importantly, you should be able to trace an intact root surface. Now let's start to assess the interproximal surfaces, and there are many of them on each side. What you will also note is that many interproximal surfaces are covered on more than one radiograph. On this image, the color-coded rings show you the same interproximal surface covered on two adjacent Bitewing radiographs. Wherever possible, make sure that you evaluate the same surface on both the premolar and the molar Bitewing radiographs. For this purpose, it's often useful to align the premolar and the molar Bitewing radiographs adjacent to each other on your screen when doing your radiological analysis. It is often useful to confirm or negate a finding that is suspicious on one view. With that, let's start to focus in on looking at the interproximal surfaces, and let's hone in on the interproximal surfaces between the mandibular first and second molar. The first step is to identify the dentino-enamel junction, the interface between the radiodensities of enamel and dentin. When there's a restoration, also evaluate the interface between dentin and the restoration. Next, evaluate the cap of enamel. Enamel is 96% mineral and appears radiopaque, more radiopaque than the adjacent dentin. The enamel should appear uniformly radiodense and continuous, with no areas of discontinuity or any areas of radiolucency. Next, examine the dentin. The mineral content of dentin is approximately 75%, so it will be less radiopaque than the adjacent enamel. Similar to enamel, the radiodensity of dentin should be uniform and radiopaque, with no areas of radiolucency. Such areas of radiolucency, especially when adjacent to the dentino-enamel junction or below restorations, might indicate the presence of caries. Now let's repeat the same process at another interdental site. The first step is to evaluate the dentino-enamel junction, that interface between the radiodense enamel and the less radiodense dentin. Next, examine the enamel, making sure that it is uniformly radiodense and continuous. And finally, examine the dentin for uniformity of radiodensity between the enamel and extending to the pulp. The next step is to evaluate the alveolar bone, and we start by evaluating the interdental bone. The edge of that interdental bone should be corticated and regular. Start by identifying the lamina dura along the root surface and trace it up to the cemento-enamel junction and to the adjacent tooth. The lamina dura will be continuous with the interdental bone. Next, identify the marginal bone. This is the crest of the facial and lingual cortical plates adjacent to the teeth. Typically, in a bitewing radiograph, the buccal and the lingual cortical plate edges will superimpose and you will see a single margin. Sometimes with periodontal disease, there may be differential resorption of the periodontal bone on the facial and lingual aspects, giving rise to two different marginal bone levels. That could be identified on the bitewing radiographs and also on the periapical radiographs. Next, identify the regions of the furcations. Note that the periodontal ligament space in the region of the furcation should be regular and of uniform width. Any widening of the periodontal ligament at this site or frank loss of the bone to this level may suggest periodontal bone loss that has involved the furcation. And likewise, we should repeat the process on the left side. You can do this in two steps. The first step is to assess the interproximal spaces, outlining the DEJ and the radiodensity of enamel and dentin. And the second step is to evaluate the periodontal bone, identifying the interdental bone, evaluating the regions of the furcation, and identifying the marginal bone levels. And with that, we will have completed a systematic assessment of all the periapical and bitewing radiographs on the full mouth radiographic examination.